Hey everyone, thank you for being here. We will get started right on time. My name is Adele, and I'm hoping you're here for the antibiotic-resistant gonorrhea training on trends, complications, and treatment. This training is hosted by HCET with our presenters Maegan Brookins and Kyla Quigley. So my name is Adele White. I'm a project manager at HCET Healthcare Education and Training, and I will be your MC for the webinar today. Let me briefly introduce you to Healthcare Education and Training. We say HCET for short. So our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate, and reproductive and sexual health education and training and care is a fundamental human right. This webinar does have closed captions available. Just a moment, I'm going to change it so you can see there. There we go. So to see the closed captions, you just click on the live transcript at the bottom of your screen, and then you can click show subtitles, and you can change the settings by going to subtitle settings. One moment. All right, and throughout the presentation, you can send your questions via the question and answer box as you think of them. You don't have to wait till the end. To submit your question, you just hover over the main screen, select the Q&A icon at the bottom, and then once you click it, a little box should appear where you can ask your question. Again, you can send questions at any time, and you can also send questions anonymously if you choose to. We will hold reading and answering all questions at the end because I know we'll have some similar questions for people. So thank you for your patience as we wait till the end to do those. Please, if you like what you heard today, please follow us on all of our social media channels. You see some of them here. And if you, one moment, please. We are going to send you after the training an email and ask you to fill out an evaluation on this training. We really, really appreciate all your feedback. This helps us improve our trainings in the future. This webinar is eligible for nursing contact hours. So make sure if you are looking for nursing contact hours, you email Kelly Bradford. Her email is listed on the screen, and she can set you up with those. All right, so this is just some housekeeping slides. I have to disclose a couple of things. There are no financial complications. There are no financial, I apologize, I'm messing up my script. There is nothing to disclose as far as financial disclosures with this. Everybody has no financial, excuse me, Jen, I'm missing the word. There are no conflicts of interest with this training. Yes, so no one with the ability to control this content has a relevant financial relationship to disclose. And now I'm really excited to introduce our presenters for the day. So Maegan Brookins, pronouns she, her, is the disease intervention specialist for the DIS team in Wisconsin. So she's the team lead for the Wisconsin Department of Health Services in the STI unit. Maegan evaluates performance measures of the state regional DIS from qualitative and quantitative points of view. She maintains the training standards and capacity for the state and regional DIS, and she assists in statewide consultation to providers and patients on all conditions of gonorrhea, including antibiotic resistance to cephalosporins, disseminated gonococcal infection, and suspected treatment failure to the recommended treatments for gonorrhea. Kyla Quigley is an epidemiologist with Wisconsin Department of Health Services, and she also serves as the epidemiology coordinator for the SURGE grant, which supports work related to antibiotic-resistant gonorrhea in Wisconsin. She is a former CSTE Applied Epidemiology Fellow and received her master's in public health from the Zilber School of Public Health in UW-Milwaukee. And without further ado, I will be turning things over to Kyla. Thank you all for being here with us.
Sorry, I was having trouble finding the right buttons. Hey, so thank you all so much for joining us. As Adele said, my name is Kyla Quigley. I am the Epidemiology Coordinator and Project Manager over Wisconsin DHS's Surge Grant. In today's talk, I will be giving you all an overview of gonorrhea, how typical infections progress, in addition to providing you all with an explanation of what antibiotic-resistant gonorrhea even is, and how our Surge Grant and program is supporting Wisconsin DHS's response to antibiotic-resistant gonorrhea. So to get us started, I'll be discussing a number of the basics of gonorrhea infections, including symptomology and how these bacteria even work from a molecular level. So starting as basic as possible, gonorrhea is a sexually transmitted infection. It's caused by a bacterium that is called Neisseria gonorrhoeae. And you can see a little picture of that bacterium on this slide. Gonorrhea itself is among one of the most commonly reported STIs in the state of Wisconsin and also nationally. And this is typically easily treated and cleared with treatment by antibiotics. For most people who acquire gonorrhea, they'll experience a more routine infection. We often think about these as uncomplicated forms of gonorrhea. These cases are going to be most easily treated with the recommended antibiotic regimens. But despite this, the more often one gets infected with gonorrhea, the more difficult treatment can become. This is because gonorrhea itself is at heightened risk for the development of antibiotic resistance. Untreated or unsuccessfully treated cases of gonorrhea can often progress to more serious courses of illness. These more serious forms of gonorrhea and more serious outcomes of gonorrhea we think of as conditions of concern. And all of those, among those include pelvic inflammatory disease, ectopic pregnancy, eye infection, or ophthalmic infection, which is often acquired at birth or through self-inoculation, where someone touches a place where they're infected with gonorrhea and then touches their eyes. There is also disseminated gonococcal infections, where gonorrhea will actually invade the bloodstream, and antibiotic-resistant gonorrhea and suspected treatment failure of gonorrhea. In today's talk and in the following slides, I'll be focusing more directly on antibiotic-resistant gonorrhea and suspected treatment failure. So gonorrhea itself can be spread through oral, anal, and or vaginal sex. This will give a bacterium, if one's partner is infected with gonorrhea, the chance to invade mucous membranes through direct skin-to-skin contact or through the swapping of bodily or sexually fluids. And again, this is only if one party is infected with gonorrhea. Those locations will often be found in genitory areas. So that means your cervix, your vagina, or your urethra. Or it could be extragenital infections, meaning the oropharynx, which is your throat, or the rectum. Now, antibiotic-resistant gonorrhea itself can be found in any of these locations and is also spread through the same way. Antibiotic-resistant gonorrhea itself can progress from a uncomplicated case of gonorrhea. In those instances, the infectious bacterium that causes gonorrhea will develop antibiotic resistance much more commonly when compared to other STIs like chlamydia. That means that gonorrhea is very different from a molecular level when compared to chlamydia, and is also why we are putting so much emphasis on antibiotic-resistant gonorrhea. So repeated infections are among the most prevalent risk factor for the development of antibiotic-resistant gonorrhea. And antibiotic-resistant gonorrhea is distinct from a routine case of gonorrhea in that treatment will not be effective in clearing the infection. Or if there is some efficacy, it won't be as effective and will take more courses of antibiotic to clear it. Also, as we're talking about gonorrhea and STIs in general, it's always important to be aware that many cases of gonorrhea are asymptomatic. If one does have symptoms, those will be the same regardless of if the gonorrhea that they have is uncomplicated or is a antibiotic resistant form of gonorrhea. Further complicating matters is that our most routinely used tests can't actually detect resistance. It's only culture-based testing as of right now that we can use to even identify a risk for reduced susceptibility to antibiotic treatment. And if one does experience symptoms, they will be pretty typical to other STIs, including abdominal pain, increased discharge, painful urination, discharge from the penis, swollen testicles, inflammation of your sexual organs, painful intercourse, unusual bleeding if you do have a vagina, or common urinary tract infections. Let's see. This slide right here provides a link to the most up-to-date treatment guidelines for gonorrhea released from the CDC in 2021. And then these guidelines also offer recommendations for clinicians to order tests of cure for certain patients that may also be at increased risk for antibiotic-resistant gonorrhea. The slide should be available after this, so please feel free to refer to the slides here or the resources at the end of the presentation to access those treatment guidelines. So now we're going to turn to building up a more thorough understanding of the history and mechanisms related to antibiotic-resistant gonorrhea. This slide provides a timeline of the treatment courses that have been introduced for gonorrhea since the 1930s. In the 1930s, this was when one of the first antibiotic regimens was introduced specifically for the treatment of gonorrhea. But as you can see, as you move along the timeline, almost as soon as we introduced a new antibiotic to treat gonorrhea, it then became resistant to that treatment. So something else would have to step in to replace it. This pattern continued throughout the 1990s and early 2000s. And in 2015, dual treatment with ceftriaxone and azithromycin was then recommended. During 2015, 2016, 2017, there were increased reports of treatment failures or suspected treatment failures. And this led to the CDC no longer recommending azithromycin for first-line treatment. And this was done to preserve its efficacy for as long as possible. So right now, only one dose of intramuscular ceftriaxone is recommended. So I'm sure at this point, you all are very, very curious about how this even happens. So antibiotic resistance itself works at the molecular level. So you're dealing with teeny tiny viral and bacterial particles that are all interacting to share DNA and pick up the ability to resist antibiotic treatment. And all of this is done through mobile genetic elements and the movement of these mobile genetic elements. And all of this includes processes whereby different bacterial cells actually pick up the ability to resist antibiotic treatment. So the these mechanisms include plasmids, which are small circular and double-stranded DNA molecules. And these will often carry genes within that whole strand that can provide bacteria with genetic advantages if those plasmids are taken up by the bacteria. There are also transposons, which are just a fraction of a full DNA sequence that can then enter the bacterial cell and then interact with the DNA within that bacterial cell to teach them how to resist antibiotics. And then the last genetic element that can confer resistance are viral phages. So these are little particles of virus that contain DNA that can then infect gonorrhea cells with resistance genes. And then once they infect that causes those bacteria to then produce more cells that contain resistance genes. And all of this is facilitated by mobile genetic movement, where these genetic elements actually enter the cell through different means of transduction, conjugation, and transformation. So transduction is when resistance genes are transferred from one microorganism to another. This would usually happen with phages. As you can see on the slide, there's a little phage on one little bacteria. It's then going to move from there to another, and then it's going to insert viral DNA inside of the bacterium. And then there's conjugation, whereby resistance genes are transferred to microorganisms when they actually connect. And then there's transformation, where a nearby gene or a nearby cell will release some genes from the cell, and then it will enter other neighboring cells, and then those will then turn into a resistant gonorrhea bacteria. So that was a lot of science. I hope it was as interesting for you all as it was for me. But now I'm going to dig back into the nitty-gritty of how we at Wisconsin DHS are responding to antibiotic-resistant gonorrhea. This work is, there are two national programs funded by the CDC that are doing this work. The first of them is the gonococcal isolate surveillance project, otherwise known as GISP. It was established in 1986 to monitor gonococcal antimicrobial resistance trends in the US, doing a good deal of lab work and data analyses. And as you can see on this map, there are a number of different GISP and SURGE sites. All of these work as collaboratively as possible to learn from one another and share best practices. The other program is the SURGE grant, which I work under. The SURGE stands for Strengthening the US Response to Resistant Gonorrhea. And we work in concert with and build upon efforts by the GISP program. Much of our work focuses on building capacity for rapid detection and our response to antibiotic-resistant gonorrhea, and it relies on increased collection of culture-based specimen so that we can do local antibiotic susceptibility testing. Oops, sorry about that. A number of the projects that we're also working on in the SURGE program is, again, increasing our ability to actually collect culture-based specimens to do antimicrobial susceptibility testing using e-test, e-swabs, or in-trace. And we're also piloting some projects related to the identification of culture-independent diagnostic testing techniques so that we can do antimicrobial susceptibility testing on remnant gnats, which are the type of tests that most jurisdictions have access to. We are also identifying best practices for rapid field investigations and continually doing data analysis to better understand the epidemiologic factors that are contributing to the spread of antibiotic-resistant gonorrhea. This work completely relies upon our really great and powerful partnerships with the Milwaukee Health Department and the Milwaukee Health Department Laboratory. We additionally support work at Milwaukee Health Department's Keenan Health Center STI clinic and 5 other community clinics within the Milwaukee area that offer STI services. Through the support, Milwaukee Health Department Laboratory has been named a Center of Excellence for the testing of antibiotic-resistant gonorrhea. This means that they at Milwaukee Health Department Lab are driving best practices for testing, diagnosis, and other techniques within our state, and serve as the hub for testing new pilot projects. Additionally, the SURGE project collaborates with other clinics and labs throughout the state. And through this collaboration, we work to ensure that more people can actually access the types of tests that help them identify antibiotic resistance, as well as suggesting best practices within the clinic and for case management. One big success story that I'd like to highlight that has come out of the SURGE program is routine updates to STI treatment guidelines. As I referenced before, between 2015 and 2021, we noticed a increased trend where azithromycin was no longer as effective in treating gonorrhea. It was the work and analyses of the different SURGE sites that helped encourage this change. They relied on our analyses and our suggestions to change the treatment recommendations. So now, within the SURGE program in the coming year and in the future, we are making a big push to enhance our identification of suspected treatment failures among people infected with gonorrhea. Suspected treatment failure can be a possibility if a patient has persistent symptoms lasting at least 3 days or more following treatment with for gonorrhea. If this is the case, then clinicians should report those cases to their state or local health department within 24 hours. This will help us at DHS to then connect with the jurisdictions who are experiencing this case, and then we can try our best to provide guidance on how to collect samples for culture-based tests of cure, and also arrange for antibiotic susceptibility testing. If the jurisdiction handling the case doesn't have access to culture-based testing, then we can help to arrange for testing through Milwaukee Health Department Laboratory at no cost to the institution who is ordering those services, as long as they are within the state of Wisconsin. So for local or tribal health departments, if they're the ones who identify the case, they can report the suspected treatment failure to the CDC, which has an existing red cap form. That form should be linked at the end of these slides in the resources slide, so please feel free to check that out if you do need to get access to it. We also ask that local and tribal health departments contact us at Wisconsin DHS just to get additional guidance and so that we can help arrange for the shipping of samples if needed. And then we can also help to provide guidance on case management and partner services. So to start closing us out, I did want to call attention to and talk through a somewhat recent article that's generated a good deal of attention for antibiotic-resistant gonorrhea. This was related to a case of antibiotic-resistant gonorrhea found in Massachusetts. The news article and a lot of the pieces that have come out around it, I think have really built up a lot of fear and anxiety around gonorrhea treatment, which is also why I wanted to talk through it. When you dig into this case to learn a little bit more, you do find that this is a confirmed case of antibiotic-resistant gonorrhea, so clearly is still of concern. But at the same time, we need to be aware that reduced susceptibility is not complete resistance or treatment failure. The samples showed reduced susceptibility, meaning that antibiotics were not as effective for treating the course of gonorrhea. Then they also did find complete resistance to previously recommended antibiotics. But then at the end of this case, after a lot of work and probably stress for that patient, they were eventually able to successfully treat the infection with a higher dose of ceftriaxone. So they were still eventually successfully treated. It just took a lot of work to get there. So also, as more attention is being paid to antibiotic-resistant gonorrhea, the CDC has not yet received any reports of a complete clinical treatment failure to one who's using cephalosporins like ceftriaxone. So this means that we still have time to improve our response. It might not last forever, but we don't have a reason to be completely afraid yet. We just need to keep working harder. So with that, here are some resources that I encourage you all to check out after the presentation, review, and also please feel free to reach out to me with any questions. And with that, I will turn it over to my colleague, Maegan Brookins. Thank you all so much.
Okay. All right. So thank you, Kyla. Hi, my name is Maegan Brookins. I'm the DIS team lead for the STI unit at DHS. I use pronouns she, her, hers. I appreciate you all being here today. My section of the webinar will be discussing disease intervention best practices in relation to antibiotic-resistant gonorrhea, ARGC for short. I will note that I will be referring to antibiotic-resistant gonorrhea as ARGC for the rest of the presentation because the title is a little bit of a mouthful. Some items that will be discussed in my presentation will be ARGC documentation and WEDS and what that looks like for local and tribal health departments versus providers, partner elicitation for partners provided from an ARGC case, and performance measures that are being done on the state level for our regional DIS and what that could look like for local tribal health departments as well. So first things first, I want to touch base on our main reporting system for communicable diseases, and that is WEDS. Most of you may be familiar with WEDS, but WEDS stands for Wisconsin Electronic Disease Surveillance System. WEDS is a web-based system that facilitates reporting, investigation, and surveillance of communicable diseases in Wisconsin. People who typically use this system are public health staff, infection control practitioners, clinical labs, clinics, and other disease reporters. I would also like to note that not everyone has the same access to WEDS as others, and some may not use WEDS to the extent of how others or the state uses WEDS. That being said, the rest of my presentation is what the state considers best practices when documenting ARGC and WEDS in regard to CDC guidance. So now let's get into the meat and potatoes of WEDS documentation of ARGC. A lot of this information may look familiar to you and how best practices look for uncomplicated gonorrhea, but with a few additional steps for ARGC. Keep in mind, it is not my intentions to overwhelm any of you during my presentation, and this is not to say you or someone is doing it wrong. This is just to inform you on what is considered best and what could be adopted in the future after this webinar. Documentation in WEDS looks a little different for both local tribal health departments and providers. As you see here, local tribal health departments have access to the patient tab, lab tab, risk tab, intervention tab, and investigation tab. As for providers, they only have access to the patient tab, the provider tab, and the investigation tab. You will see throughout this presentation that just because each entity doesn't have the same access to the same tabs, both entities have similar access to most of the same subsections within each of those tabs, which we will go into more detail soon. Starting off with the first tab that both local tribal health departments and providers have access to is the patient tab. Information on this tab that is useful to have are the areas highlighted in yellow. In addition to those yellow fields, what's best to have would be phone numbers, language spoken, and marital status. We recommend filling out these fields because it is where those who will be contacting the patient will have the information they need to locate and interview the patient appropriately. As mentioned before, there are subsections within each tab for both local tribal health departments and providers. We will go into more detail on each subsection, but just so you have an idea of what is on each tab. So the providers only tab, you can see that everything is all in one place, and there are about 9 sections that are required and recommended for review and to be filled out to the best of your ability. For local tribal health departments, the next 3 slides, you'll see some similar subsection headings that were in the providers only tab that you will see spread out throughout the 3 tabs for local tribal health departments, which include the lab tab with about 8 recommended subsections. And then the risk tab here with about 3 recommended subsections, and the intervention tab with about 4 to 6 recommended subsections to be filled out. The first subsection that I do want to point out that is the first thing in the local tribal health department's lab tab and the first thing in the providers only tab, and that is the lab affiliated subsections. These subsections will show a lab widget section, laboratory testing, and then also the filing cabinet. So lab widget summary is where electronic records will be presented. Laboratory testing section is where a lab test would be manually entered if there is no electronic record uploaded to the case. For example, if you are notified of a test and it was not uploaded through WEDS, you would document the specimen source, whether that be urine, blood, etc., the date the specimen was collected, where the specimen was collected, what type of test performed, whether that be a NAT or a PCR, the result from the test, whether that be positive or negative. The filing cabinet comes into play for if you wanted to see where all electronically reported labs are housed, where web reports can be found, and where any other documents related to the case can be shown or uploaded to. If you're unfamiliar, the filing cabinet is not pictured here, but you can find it at the top of the WEDS case page, and it looks just like a filing cabinet. Continuing with the topic of testing and mentioned previously in Kyla's presentation for ARGC, there is specific testing that needs to be completed called antimicrobial susceptibility testing. This testing would also be documented in the AST subsection on the lab tab for local tribal health departments. And if it's not documented there, somewhere in the lab reporting area, as seen on the slide before, would suffice. Along with this testing, there is the suspected treatment failure protocol as well. There will be an STF form and documentation fields in WEDS to come. For now, on the next couple slides, there are a few further questions from the STF form that are recommended to have documented somewhere in the case in addition. I also just want to note that some of these questions may be able to be auto-populated from other fields throughout documentation, but until we can get that form up and running in WEDS, this is what we consider as best practice. So some questions from the STF form that are not currently in WEDS, but will be soon. These questions include information regarding antibiotics given in recent months, initial and follow-up evaluation information, and partners treatment information. The next subsection is the HIV status and testing section that's only available to local and tribal health departments. In this section, it's recommended to document HIV testing and results, any PrEP use, and if not tested for HIV, was the patient referred for testing? It's always good to know a person's HIV status to make sure they don't need any further resources. Next subsection that's available to both local tribal health departments and providers is the STI signs and symptoms section. It is recommended to record any signs and symptoms specific to gonorrhea. If no symptoms are reported, it's best to leave this section blank. We may be able to get a drop down or some kind of bubble selection to select as no symptoms reported with WEDS, but until we have that option available, leaving this section blank is best. Also wanted to note some common gonorrhea symptoms that are reported in WEDS. Those that are highlighted in yellow are the most common. Just want to caveat to that. If a patient has experienced epididymitis, they should be going to the emergency room as soon as possible because that is a very painful symptom. Along with symptoms, there is a STI complication section still available to both entities and recommended to be filled out if a complication applies, and was also touched on in Kyla's presentation as well. It is not uncommon to have a patient who has a co-infection with another STI, and if that is the case, then the STI co-infection section should be filled out completely. Other STIs that could be documented here include chlamydia, syphilis, people living with HIV, etc. This section is also only accessible to local tribal health departments. It is also not uncommon for a patient to have previous STI history, and if that is the case, the previous STI history section should be completed with any previous history of gonorrhea along with the previous incident ID associated. You can include multiple events or incidents if there is more than one history of gonorrhea. And also, if the history is out of jurisdiction or out of state, you can document the county or state that that incident happened in the incident ID field. This section also is only available to local tribal health departments as well. The pregnancy section, which is something that has sparked more interest in the STI world. This is a section that's recommended to be completed to the best of your ability, especially if a co-diagnosis with syphilis becomes apparent and then gets sent to the state DIS instead for further follow-up and intervention. Accessible to only local tribal health departments, the risk assessment is the lengthiest part, but is a good part in learning more about the patient's sexual behaviors and the partner or partners involved. The risk assessment includes the STI risk factors, interview period, sex partners, and injection or non-injection drug use sections. Each section is recommended to be filled out based on conversation with the patient. This is where rapport will be your biggest friend and where you'll get the most information from your patient based on simple conversation. These sections are recommended to be filled out regardless if the risks assessed are identified or not, or if the interview is completed or not. If a patient declines some questions, that's not considered a complete refusal. Just please fill in the questions that they do answer to the best of your ability based on what's discussed and mentioned in your conversation. So some of these questions are worded poorly and may be stigmatizing to your patient. So it's good practice to keep these questions open-ended and non-shaming. If you know a question is going to affect your patient in some way, don't ask it and move on. If given the opportunity to discuss sex partner or sex partners, it is always good to continue to be non-shaming and open-minded when talking about the number of partners within a certain time period, and just keeping in mind that no number of sex partners is too high or too low. Drug use can also be a touchy subject, so remaining open-minded and being sure to be specific in what types of drugs and what form the drugs are in. This will also help in determining how they are using the drugs or who they are using the drugs with, and may diminish the number of questions that you ask as well. The treatment section, the most important section of all, the STI treatment mandatory section that is accessible to both local tribal health departments and providers. It is not only a mandatory section through the CDC, but also the most important section for the patient. This section does get frequently missed, so this needs to be completed if treatment is known or not. If treatment is given, it is recommended to complete in full per 2021 CDC STI treatment guidelines. The STI condition should also match the disease of diagnosis unless testing proves resistant gonorrhea. If alternative treatment is necessary, it's also best to document why. So for example, if there was an allergy, if the patient's afraid of needles, or if resistance was a factor. As for provider name, only document provider if the provider of the treatment is different from the one who tested the patient. And if there is more than one provider who utilized for treatment, you can add more than one treatment field. And if the patient is undertreated or inadequately treated, you should mark the patient as not treated per the CDC treatment recommendations. In addition to treatment for the patient, there is expedited partner therapy, EPT, and there is test of cure, TOC. These sections are both accessible to local tribal health departments and providers. Expedited partner therapy is the clinical practice of treating the sex partner or partners of patients diagnosed with chlamydia or gonorrhea by providing prescriptions or medications to the patient to take to their partner or partners without the healthcare provider first examining them. If STF and ARGC is established for the patient, then AST is recommended for partner or partners who may be at risk as well. Test of cure should be followed based on test of cure protocol with respect to the timeline of the case. Test of cure is similar to original testing where cultures are collected for AST from all sites of infection if reduced susceptibility is of concern. Local tribal health departments and providers have access to documenting and following up with this information. If there is a partner or partners at risk for STF and ARGC, then it is best to perform partner elicitation. In partner elicitation, it is best to gather as much information on partner or partners from the index case. Some common information that you'd want to gather would be along the lines of like name, date of birth, address, phone number, race, ethnicity, time of exposure, types of sex performed, whether that be anal, oral, or vaginal, any drug use, and there may be other questions that you may need to ask too, but that just is dependent on case-to-case basis. And then you'll go on to contacting the partner themselves, notifying them of the exposure, recommending the correct testing, getting cultures and specimens collected for AST, and then ensuring treatment and test of cure for positive contacts, and then if there needs to be any further epi investigation follow-up. Once a contact is identified and there's enough information to put them into WEDS, you will enter each contact or contacts as separate ID numbers. So if you have one contact, there'll be ID 001, and if you have more than one, it'll be 002, 003, so on. You'll also see that a CI will have two people, one blue shirted person and one green shirted person. That is to ensure that you're creating a contact investigation and not a disease incident. We do not want to create a disease incident at this point in time. As you can see here, when creating a contact, this is where you'll put in the name information, address information, and date of birth for that contact. I will note that be sure to assign yourself as the investigator as soon as possible when creating a CI so it doesn't get lost in WEDS. And then also ensuring like the type of contact this contact is P1 through P3. So P1 would be a partner, a sexual partner, P2 would be a needle sharing partner, and then P3 would be a both sex and needle sharing partner. And then also being sure to save these contacts and creating the contact information for each contact that is identified. The last and final tab is the investigation tab, which is accessible to local tribal health departments and providers. The fields that are recommended to be filled out are those highlighted in yellow. And in addition to those, the investigator, slot, date close, episode date, and final disposition. And final dispositions will range between A through F and C. And I will go into detail on those too. When a case is complete and ready to be finalized, these are the best practices in doing so. So your process status will be set to final. Your resolution status will be set to either confirmed, suspect, or not a case, all depending on how the testing came out. And then final disposition being set A through F or Z, depending on testing and treatment. So to the left, you can see that these are the most common and most recent dispositions that you probably have seen or used yourself in finalizing a case. And then to the right are the dispositions recommended using based off of disease intervention best practices, based off of treatment and testing for the patient. There are CDC specific definitions for each disposition, but for time's sake and for the recommended ones, I have simplified them a little bit. So A, for preventative treatment, patient was tested, infection not found, and they wanted preventative treatment. Refused preventative treatment, patient was tested, infection not found, did not want preventative treatment. Infected, brought to treatment, DIS interviewed the patient, patient has not yet been treated, DIS assisted in helping schedule treatment. Infected, not treated, DIS could not locate the patient or patient refused treatment altogether, then the patient was not treated at the testing location or anywhere else that was known. Previously treated for this infection, DIS interviewed the patient. Patient has been treated prior to DIS contact, but after the exposure. DIS did not assist with treatment scheduling. Not infected, DIS or provider reports a negative test, therefore not infected with the infection. Previous preventative treatment, patient received preventative treatment prior to the DIS being involved in the case. And these will all change depending on case to case and how the treatment and testing came about. Now, at the state level, we have regional DIS that are measured based on their performances on WEDS documentation, partner elicitation, and timeliness of completing a case. This data allows us to see where our DIS could use improvements and to see what amazing work our DIS are doing. In order to get information for these performance measures, we ask our DIS to complete the STI reporting and interview information section. This allows us to pull data based on interview completion or not. In addition to the last section discussed, we also require the STI interview dates and period section to be filled out as well. This section allows us to pull data on how long an interview was assigned out, how long it took to get an interview for this patient, etc. We also recommend all local tribal health departments and state level DIS to fill out the attempts to contact section. This section allows reviewers and people who need more information on the case to see how interviews went, how often contact was made, was there any communication with the provider, etc. In conclusion, the key takeaways that I want to remind you all of is that today was to show you the best practices to documenting ARGC that will help in keeping the patient on track with testing and treatment. And with that, having DIS, local tribal health departments, and providers to keep up to date on treatment and testing recommendations by the CDC. I also just want you to know that you're not alone in any interventions like this. I'm here to help where I can, and I'm sure Kyla can attest that she is more than happy to help as well. And here are some further references and resources that may be of benefit for you. I just want to say that I appreciate you taking the time to listen in today. Please use me as a resource for any documentation, partner elicitation, or performance measures that you may need now or in the future. Thank you. And say back to Kyla.
All right, thank you all. So to wrap us up, I will be presenting on some slides that the STI unit at Wisconsin DHS's STI epidemiologist put together. And her name is Donna Shritha. She is fantastic and unfortunately could not be present for today's webinar, which is why I'm presenting on her behalf. Okay. So in this presentation, we will be discussing STI data, how it's collected, how it's reported, covering some pertinent rates related to gonorrhea, and then additionally breaking down the data by age, sex, and race and ethnicity. I'll also be briefly touching on disseminated gonococcal infections, just to provide a bit more information on those. And then lastly, closing out with a quick summary on how well we in Wisconsin are doing at documenting the gonorrhea treatment. So as we all picked up from Megan's great presentation, WEDS is our hub at Wisconsin DHS for STI data. All of this data comes from either local providers and local labs reporting to their nearest local and tribal health department, and then those health departments would filter the information into WEDS, or if those providers and labs have EHR, electronic health records set up, those may automatically enter into WEDS. And then also, because we will be covering a bit of data in this presentation, I want to make sure to start off with just a little warning about STI data. For one, we can only count the cases that we actually detect. As I've already presented and discussed, asymptomatic infection is common with STIs. So if one doesn't know that they're sick, there's a good chance that they won't get tested, and then that case won't be present in our system. There's also issues of access to testing services, leading to further underreporting or uneven reporting of STIs. And then, as we've all picked up from Megan's presentation, there are a lot of data fields in WEDS, so it might be common for busier jurisdictions to not fill out the information in full, and then that incomplete data can also kind of limit our view and understanding of STIs. So I guess to sum that up, the data that we have is still very good and rich, but there are a lot of caveats to keep in mind as we're thinking through these data. So the next slides that I'll be presenting on focus on the most recent full year of data that we have available, which is 2022, and restricted to cases occurring within the state of Wisconsin. So gonorrhea itself made up about a quarter of the number of reported and diagnosed cases of STIs within Wisconsin. And that's really only thinking through the three most prominent STIs, gonorrhea, chlamydia, and syphilis. As we can see here, chlamydia still does make up the broad majority of the STIs that we'll see in Wisconsin. Gonorrhea is still the second most prevalent, and as I'm sure anyone on this call who does work with STIs is aware, syphilis is becoming more and more of a concern. So focusing on specific trends within the state of Wisconsin, we can see that over time, there's been a pretty steady and persistent increase in the burden of gonorrhea within the state. This slide presents the rate of reported cases per 100,000 people within Wisconsin. So as we can see, there has also been a more recent decline. Starting in 2021, the number of cases diagnosed in Wisconsin dropped by about 16.6%. And our recent data in 2023 does suggest that this trend might be continuing. But again, data for 2023 aren't complete, so we'll need a little bit more time to understand what's going on here. So then we also would like to know, how are we doing in comparison to our neighbors? And honestly, it looks like we are doing pretty well for the Midwest. Wisconsin, as of 2021, had lower rates than most of our nearby Midwestern neighbors, with Illinois topping out the Midwestern states for their number of reported cases. And then Wisconsin is also doing better than the national average, which is great to see. So then nationally and in Wisconsin, though, I do want us to really keep that first graph in mind. There has been a steady and persistent increase in the number of STIs reported, both in Wisconsin and nationally. These two maps give a view of the rates of reported cases in each US state. The graph to the left, as you can see, there's a whole lot of yellow and green on those maps. Those are states that had lower rates of gonorrhea in comparison to other states in 2012. Then when we look over to 2021, we see a lot more dark blue. Those darker blue colors suggest higher rates of gonorrhea. So what we can see here is that not only are more states experiencing gonorrhea for maybe the first time it becoming a big problem, but also those who have always been dealing with gonorrhea are seeing increases in the rates observed. This remains true when we look within the state of Wisconsin. So the graph on the left shows all of the different counties throughout Wisconsin. And then the graph to the right also shows all of the counties within Wisconsin. Those that are in that yellow, light orange color on the left, those are areas that had no reported gonorrhea cases in 2012. When we look over to 2022, there are only very few counties without any reported gonorrhea cases. And then a number of those counties that have always had a kind of higher than average burden of gonorrhea, in many of those counties, the burden is just growing as of 2022. And then before I move on to some of the rates of gonorrhea broken down by demographic group, it's very important that we all hold in mind the context in which all of this arises. Individual health is very, very heavily influenced by the relationships you have with those around you. All of that is influenced by the community in which you're living. And then all of that is even more influenced by society. Society has a number of policies and practices that all influence how we're all living and how we're all growing and our own health. So again, individual health cannot be divorced from the context and the society in which a person is living. As we think through responding to STIs and sexual health in general, we have to think of a continuum of care. We have to be both increasing access to sexual health services while also providing more great sexual health education, which our partners at HCET are doing a wonderful job of doing. And then within all of this, we have to be providing and facilitating safe and supportive environments where people can learn about their health, can experience ill health, and then get help dealing with it. So now that we have that full understanding, now we can look at some of the different demographic groups who are experiencing a greater burden of gonorrhea. When we break this down by age group, this graph right here, each of the bars on that graph shows the rate for a different year from 2018 to 2022, broken down for the different demographic or the different age groups present on the slide. What we can see here is that gonorrhea tends to be highest for those aged 20 to 24. Then in Wisconsin, this tends to be lowest for those aged 40 to 49. Older age groups aren't present on this graph, but the trend does continue that way, with those aged 50 and above having similarly low rates of gonorrhea detected. And then just to bring it back to the time component that I touched on earlier, from 2018 to 2020, for the most part, across most age groups, we saw a steady increase over time in the rate of gonorrhea across age groups. In the more recent period, from 2021 to 2022, we saw further declines. There's definitely some variation in those age groups and the data for those age groups, but in general, it went up and then it went down. This remains true if you break it down by sex. So in general, biologically male persons in Wisconsin do tend to have a higher rate of gonorrhea compared to those who are biologically female. And then for all sexes, it increased pretty steadily from 2018 to 2021. And then more recently, we've been seeing declines across all sexes. Additionally, certain race and ethnic groups are more commonly diagnosed with gonorrhea, and this tends to be greater in comparison to their share of the population. So what this slide shows is that Black residents of Wisconsin tend to be disproportionately burdened by gonorrhea in comparison to their share of the population. But when we look at our white and Asian members of the state, the share is lower in comparison to their share of the population. And then while I have been focusing on a number of more recent decreases in the rate and burden of gonorrhea broken down by race and ethnicity, among all groups, the one that we are seeing as a bit of an increase in is among Native American residents of Wisconsin. So just once more, just highlighting a more recent decline in the number of cases identified among Black residents, Asian residents, and white residents of Wisconsin. Then when we look at all of these figures regionally, the southeastern region of Wisconsin has routinely the highest rate of gonorrhea in comparison to other regions. The southeastern region contains the city of Milwaukee and Milwaukee County, which again, they do have the highest burden of gonorrhea compared to other regions, which is also why the Surge Grant is piloting programs within Milwaukee and why the bulk of our surge work has focused on Milwaukee in the first couple years of the program. But despite this, again, I do want to highlight the good news. Since 2021, all regions have seen decreases in the number and rate of gonorrhea cases diagnosed. Okay. The decrease has been highest in the southern and northern regions, with a 37% and 38% drop in cases since 2021, respective to those regions. So now I'm just going to underline some of what was discussed in Maegan's presentation with the documentation of gonorrhea treatment. So in 2022, the majority of gonorrhea cases did have their treatment documented at about 61%, which is great. The majority of us are doing a great job in documenting those treatments, but 39% did not have the treatment documented. And this means that we at DHS and anyone else who is a member of the local and tribal health department, we might need to work together more just to make sure that this is being more commonly documented on cases. And then within that, we also try and break down the treatment that is documented by those that are following CDC recommended treatment regimens and those who are not. And more great news, we in the state of Wisconsin are doing a good job on sticking to the new and recommended treatment. Only about 3% were not documenting with the recommended treatment. And with those cases, that's part of why it's so important to give the reason why a certain treatment regimen may have been entered if it's outside of the CDC recommended one, just so that we have some understanding of what's going on with that case. And now, disseminated gonococcal infections, which if you all remember from my talk at the beginning, I highlighted as a condition of concern for gonorrhea. So DGI, it is uncommon, but we are getting more reports of DGI throughout the state. It's a severe complication of gonorrhea that arises if the gonorrhea infection is not treated or not successfully treated. And then one remains sick long enough where the gonorrhea can actually invade the bloodstream. And then once it does that, then it can progress to other areas of the body and just cause a more difficultly managed illness. So as I said, we are getting more reports of DGI, but this isn't happening in a vacuum. We are still seeing less DGI than we have in more recent years. Again, we're still monitoring our 2023 data just to make sure that this trend is actually a true trend, or if something may have been happening that was a little funny in 2022. And then DGI is likely to happen where gonorrhea is more common. There are more cases, more people might be missed, more people might even have resistant forms of gonorrhea that might lead to DGI as a result of an unsuccessful treatment. So those counties where we're seeing DGI most often from 2019 to 2022 are within Dane County and Milwaukee County. And then again, we can only deal with the information that we have present. So if a treatment isn't entered into WEDS, from our end, it looks like those cases of DGI are not treated. And unfortunately, even though we had fewer cases of DGI in 2022, there were a greater number of those cases that were not treated in comparison to other years. So of the 10 cases of DGI that we identified in 2022, half didn't receive treatment from our end. There is a chance that they were treated by their clinician, by their physician, and that information didn't get entered. But from our end, it looks like we need to do more work to make sure that any person who presents with DGI is getting treatment as fast as possible. But all this being said, those who did get treated were treated with the CDC recommended treatment on average. There were still some cases that received an alternate regimen or a not CDC recommended regimen. So again, more work might be needed here just to understand either why the recommended treatment wasn't used, or if education might be necessary just to ensure that we know how we should be dealing with these cases of DGI. So just to turn back to gonorrhea, again, Milwaukee accounts for just the majority of cases of gonorrhea that we see within the state of Wisconsin, making up about 61%, while all other counties account for 39% combined. And then, as we all might be aware, STIs do tend to pattern based off of region. So within the state of Milwaukee, we do see a lot of variation in where the burden is highest for gonorrhea, and it is restricted to these zip codes. And a number of those zip codes also are some of the most resource poor areas of the city of Milwaukee as well. And then this is just another way of showing what I've already discussed. Milwaukee does have a disproportionately high burden of gonorrhea. Again, that's why the SURGE program is working so closely with members of Milwaukee, just to make sure that our response is as relevant to the people who really need the help as possible. This graph might be a little bit hard to digest, but the numbers in the middle are age groups. And then the bars to the left and right of those show the rates for those specific age groups. So in purple, those are the rates for Milwaukee County. And then in blue, those are the rates for all other Wisconsin counties. And we can see that the trends do follow similar lines, with the highest rates being observed among those 20 to 24 across the board. With those being highest among those 20 to 24 across the board, and then also high among even younger age groups, and then lowest among older age groups. And then this also follows other patterns when you break it down by sex. So biologically male persons, all biologically male persons in Milwaukee County are actually actually have a lower rate of gonorrhea when compared to biologically female members of Milwaukee County. So if you all remember one of the first slides that I showed, this is a complete reverse of the trend that we see statewide. So in Milwaukee, biologically female persons tend to be more at risk for gonorrhea or presenting for treatment more routinely than males within Milwaukee County. And then just again, many of the other demographic trends that we've seen previously hold true in Milwaukee County as well, with Black residents of the city being most burdened by gonorrhea. And then we can also see from this in blue that Black residents of other counties are also disproportionately burdened in comparison to other race and ethnicities examined. And then treatment again, within Milwaukee County, we are also seeing a number of cases where treatment is not documented, with only 44% showing treatment being documented. So we in the SURGE program and our wonderful partners in Wisconsin are working really closely just to improve our documentation within the county. But again, within Milwaukee, they are doing a good job of following the recommended regimen for treatment of gonorrhea. Some of the key takeaways, just to sum us up, is that gonorrhea is most impactful for those aged 15 to 29, Black residents of our state, men, and then also those who are living in Milwaukee County. The good news that we can walk away with is that it does seem that cases are decreasing in the state of Wisconsin, with about a 17% decline from 2021 to 2022. It does take some time to understand a trend to be a true trend. So we're going to have to keep monitoring this closely to understand how true this is and how persistent the trend will be. And then also that documentation of cases and treatment, it's very important for us. We, again, can only work with the data that we have at hand. So the more complete your reporting and documentation is, the easier it is for us to understand what help might be needed. So thank you. Before I go on, I just want to make sure to do another shout out to Donna Shritha. Again, she's our STI epidemiologist. She produced these slides and found that very cute dog picture. So thank you all so much.
Thank you, Kyla and Megan. I learned a lot from that. I hope you all did too. So right now, take a couple seconds. People can send in their questions using the little Q&A icon at the bottom. And I'm just going to give you a couple of reminders while people are getting their questions in. So this presentation will be archived, and a list of upcoming events can also be found on our website along with this archived presentation. And just a reminder about those who want to receive nursing contact hours for this event. If you want to do that, you must do the following. So attend the entire webinar. If you're still here, you've done that. You must return the completed evaluation or post-test, which will be sent after this webinar is over, and complete the nursing hour contact form and email it to Kelly Bradford. That email is kbradford@hcet.org, and you can also find it on the slides, which will be sent after this. And it looks like we do have a few questions already, so I am going to go ahead and display those. Just a second. If I can click. Oh, quick, before we do questions, I just want to remind you all of the Wisconsin STI Summit. Those of you who are in Wisconsin, this is most pertinent to you, but that will be happening on Wednesday, October 11th. And Thursday, October 12th. If you did not receive a notification about this, feel free to shoot me an email. I can forward it to you. My email is awhite, A as in apple, white spelled like the color, @hcet.org. You can also reply to the evaluation email to let me know if you didn't get it, and I can forward it to you. But yeah, would love to see you all at that. And well, thank you for those of you who are putting in your questions. We'll get to them in just a second. You can check out our virtual learning opportunities. We have lots of them on our website. They're really great. I've gone through a lot of them myself because I'm new at HCET. They're at learn.hcet.org. Let me now see what questions we can answer for you. So, someone writes, are your slides available? The email that was sent out with the Zoom link said the slides were available, but I couldn't ask them with Outlook. Thank you. They will be available after this in the follow-up email. And then you can also see them on the webinar, which will be hosted on our website. Sometimes it takes a couple days to get on there, but you'll be able to access our website through the link in the follow-up email that will be sent after this, along with the evaluation. Another question, what transport system do you use for suspected treatment failures of gonorrhea identified outside the surge clinic jurisdictions? That's probably a question for Kyla.
Yeah, thank you so much for that question. So for transport, we currently work with a courier service that can go pick up samples and then return to a Milwaukee Health Department lab. Unfortunately, there are a little bit of complications with that. So for us, it works most effectively, especially if you're at a further area of the state, if the appointment to collect the sample could be made earlier in the day and then also not on a Friday. One complicating factor with all of this is that we need to get the samples back to the lab within about 24 hours to make sure that they stay stable and that we can effectively do testing on it. We are currently in the planning stages of trying to improve the process and make it easier, especially if you are all the way up north. And so more information on that will be available. And then further information on this went out in the form of a medical guidance document discussing suspected treatment failure a couple weeks back through Wisconsin DHS. And then these will all be hosted on the Wisconsin DHS website under a antibiotic resistant gonorrhea page. It's not currently deployed on the website, but it should be any week now. You should be able to go into the Wisconsin DHS page, type in antibiotic resistant gonorrhea, find it, and then you can find the fact sheets and more information on that. And then if you were wondering about the materials that are sent in transport, what we send are e-swabs. So it's a white e-swab for oral, vaginal, or cervical collection, or a green e-swab that can be used for urethral or penile collection. Yeah, please let me know if you have any other questions. And then my email is on the slides too, so feel free to reach out via email and we can talk through this in more detail.
Wonderful. Thank you, Kyla. Another question that we have is, so are you going to cover diagnostic criteria for DGI? Is that something we can talk about, or perhaps you could guide us to another resource?
Yeah, so again, that'll be another resource that will be on the website. There are a number of resources through the CDC, also linked in our slides. And then if you just need a kind of quick and dirty guide, within WEDS, there's a section called confirmation criteria. And then when you expand that, it does give you the case definition for DGI that can be used for diagnostic criteria. If you are still looking for more resources and more information on that, please again reach out via email and I can help discuss that with you in more detail.
Okay, cool. And I will click back to Kyla's email in the slides as soon as I'm done answering questions. So thank you for that. Another question is, could the preferred fields for antibiotic gonorrhea in WEDS documentation be available as a standalone document for easy reference, either maybe on a SharePoint or somewhere else?
So we have a rough draft reference sheet that is internal right now, but we can easily put something together for the public and for local health departments to reference.
I think that is our last question as of now. And I apologize, Jen. I accidentally clicked out of our PowerPoint. I'm trying to go back to the slide that has Kyla's email address, if you can assist me with doing that. Thank you to Jen, who's doing our behind the scenes technical assistance. In the meantime, oh, looks like Jen's got it. I won't touch. Thank you. So I see Kyla's information. Let me see. In the meantime, there we are. Awesome. Thank you. So for those of you who had specific questions about the way Surge works, including mailing samples and things like that, there's Kyla's email address on the screen. And like she said, the website will be updated soon. I know Kyla, if you email her, is happy to share that link with you too once it goes live. There's going to be some great stuff on there. I've been able to see some of the things that goes on there. Let me check and see if we have any other questions. I don't see anything else right now. Thank you all for participating today. I'm super happy that we had such a big audience. And again, look out in your email for, oh, we have one more questions. Thank you. For consistency, should the local tribal health departments be using the same final dispositions listed in the antibiotic resistant gonorrhea WEDS documentation for all chlamydia and gonorrhea DIS?
That would be our best practice. I know it might be something that will take time to do and getting everyone on the same page, but in the future, that's what the plan is to get everyone using the same ones so that our data can be more cohesive.
Okay. Thank you, Megan. Yeah, great questions, all of you. I'll wait just a second to see if any more pop in, but thank you all for being here. Thank you to Kyla and Megan and Jen at HCET for our technical assistance. And yeah, if you all enjoy the rest of your Wednesday, thank you so much. I will let us go since I don't see more people popping questions in. Thank you all so much for being here.
Thank you.